We will get started with the next session. We are a little bit late. We can get started though with the first speaker, Alberto. You're the first.
Thank you, Simo. Let me see if I can move. Yeah. Oops. Okay. So I'm going to talk to you about a product on which we have been working for for more than 10 years, actually, since 2011. And this is a prodrug, a lipophilic prodrug of Mitomycin C, which was specially designed for delivery by Pegylated liposomes. And these are my disclosures. And as a first slide, I would like to, these things have been already mentioned by several speakers, but I would like just to restate some of the advantages of liposomes versus other drug carriers in drug delivery. There is an extensive understanding of the biophysics of the component materials of liposomes. There are very good GMP lipid sources, robust manufacturing protocols, and we also have analytical protocols that are well developed. There is a good understanding of the PK and biodistribution of liposomes. They are, as you well know, biocompatible and biodegradable components. The regulatory pathway is being defined, and we can perhaps have an EPR assessment, an assessment of the EPR effect to know whether the biodistribution of liposomes is satisfactory, and perhaps this is going to become feasible in the next few years. They can confer delivery of water-soluble or lipophilic drugs in an efficient way, and you can also deliver multiple drugs in the same liposome. Now, this is the product we developed, which has undergone minimal changes in these last 10 years. We refer to it as Promitil, prodrug of Mitomycin C in liposomes. It has a long circulation time. It exploits the abnormal blood vessels for selective delivery of MLP, which is the name of the prodrug, by the EPR effect to tumors. And you see here a cartoon of the liposome. You see the cryo-electron microscopy. They are spherical liposomes, around 100 nanometer diameters. And this is the product is a suspension of liposomes, which is extremely robust in terms of stability. It has 5 years at least of stability, which is actually fantastic for a liposome product and for any liquid product kept at 5 degrees. So here you have the more detailed view of the structure of the product, which was designed by my colleague Samuel Zalipsky back when in his years at ALSA in California. And it contains Mitomycin C, the drug, which is a potent drug, and it is a strong cross-linker with high DNA affinity to DNA. This is what he used is a spacer that is the linker, that is the thiobenzyl group that actually it is stable in circulation, and only if thiolytically cleaved, it releases really the drug, Mitomycin C. And on the other side of this linker, we have 2 long chain of fatty acids with a glycerol, 2 stearic acid molecules to provide avid association with the liposome membrane. So here you see the linker and the hydrophobic anchor of the prodrug to the liposome bilayer. And I'm not going to waste too much time here, but this is just to tell you that thiol-induced activation, if you have free thiols around, you can activate this lipidic product to Mitomycin C, and then the byproducts are really not any, they don't have any side effects. Cysteine, as you see here, cysteine diacetyl glycerol, and also thioquinone methide. And these things can be seen easily in vitro using many reducing agents such as N-acetylcysteine, DTT, and many others. And as you see in the plot on the far end side from me, you can see that when you take the formulation of this product, which we call PLMLP, without a reducing agent in culture, it has hardly any cytotoxic effect. When you add DTT, the cytotoxic effect actually jumps up to nearly the levels of free mitomycin C. But actually, DTT doesn't do anything to the free mitomycin C. So this is just to show you how dependent is on the activity of this product on the thyrolytic cleavage. It is stable in plasma. The formulation is able to protect the product from albumin and other thiol-containing, cysteine-containing residues of proteins. And you can see here that even after 24 hours, we can see practically by HPLC no mitomycin C peak, that is, no cleavage of the prodrug, which, as I mentioned before, we refer to it as MLP. So we had good plasma stability. We have done some ex vivo assays, both in working with extracts of tissues to show that actually while the product is stable in plasma, it is actually very quickly degraded in tissues. We have shown that in liver, in spleen, in kidney, and even in tumor in animal models. And then we have actually taken tissue explants from patients undergoing surgery, which have and we have exposed tumor tissue from these patients and normal tissue from the same patient. And as you see here in this study that we published a couple of years ago, actually 1 year ago, we had 17 patients here and only 3 in the red. You see there are 3 red dots. Only in 3 cases, the normal tissue would cleave more than the tumor tissue. So not only we have in the tissues thyrolytic activators of the product, but in most cases, the tumor is much richer than normal tissues in these thyrolytic activators, which is actually what we are looking for, to have some tissue-specific cancer effect. And I'm going to pass through these slides quickly because this is really the same thing, but in vivo, showing that in the tissues we hardly see in blue any levels of MLP, but the liposomes are still around, so the prodrug is being cleaved, and the liposomes are still there. And here there are a few slides on in vivo therapeutic efficacy. I'm going to pass very quickly through them. This is a colon cancer model in mice. You can see that the PLMLP beats free mitomycin C. The Promitil is in red. The free drug is in blue. And here there are other studies. This is in a KB model in which PLMLP beats cisplatin, which is a standard drug for cervical cancer in terms of activity, and other models in gastric cancer, in pancreatic cancer, in which you see that the PLMLP is more active than gemcitabine and than irinotecan, the drugs which are standard comparators in these models. Another model, which I'm going to really pass by quickly, in a drug-resistant tumor, in which also PLMLP is more active than Doxil, cisplatin, and free doxorubicin. So the other thing that we have seen in more recent studies is that combination gives you a tremendous advantage with Promitil. If you combine here with paclitaxel, practically we cure all the mice, as you see in the bottom plot, the lower plot to this side, to the side near me, or practically complete regression in all tumors. Also, we have seen with Doxil fantastic results in combination. So another study in which we see also a nice additive effect with anti-PD-1 in a drug-resistant tumor with 4 out of 8 tumor-free animals in the Promitil plus anti-PD-1 group, as opposed to Promitil alone. And as you see over there, the other groups which are not active against this tumor because of the MDR resistance, which is particular to this tumor model. So we have gone into phase 1 studies, and in fact, we have treated already 155 patients by December 22. But again, as interestingly, as Patrick Couvreur was saying, we didn't reach the phase 2 studies. So phase 1A, dose escalation, pharmacokinetics. We have done phase 1B in colorectal cancer, phase 1B in combination with FOLFOX chemotherapy, and also in combination with radiotherapy and compassionate use in many patients, in 39 patients. And while we see many stabilizations in patients in phase 1Bs, the most significant anti-tumor effects have been seen in combination with radiotherapy. In fact, we had a terrific result with 16 out of 18 evaluable patients in the phase 1B of Promitil with radiotherapy with disease control after several months after chemotherapy and radiotherapy, after chemoradiotherapy. I'm going to skip these pharmacokinetic studies in humans because they have already been published, and also these slides. I would like just to show you another thing that is interesting, the fact that the circulation time of MLP may predict clinical response, because this is connected to the EPR effect. In fact, if we, among the patients who were in the phase 1B in colon cancer, who remained stable for 3 cycles, we had a median half-life of 26 hours, while in the case of patients who progressed, we had a mean half-life of 20 hours only. So as you see again, keeping the circulation it's important, and we think that there are inflammatory aspects that bad prognosis patients that accelerate the clearance of Promitil and actually make the results worse. This is another, I will skip this slide in the interest of time, and I will also skip this slide, just to show you, as you can read here, that some inflammatory parameters like high neutrophil count or CEA level, they correlated with faster clearance and shorter T-half, and longer circulation of time of the liposomal prodrug and stable disease were indicative of extended survival. And just to show you that we have a mechanistic approach and explanation for the synergistic effect between radiotherapy and Promitil. In fact, these experiments were done in a preclinical model by Dr. Andrew Wang, who was then at University of Northern Carolina. Since then, he has moved to Texas. But what he found out is that Promitil reaches the tumor via the EPR effect, as you see in this cartoon. And then once you irradiate the tumor, the damaged cells, in order to try to because of the oxidative, the free radicals generated by radiation, they upregulate and they release many reducing agents, many SH groups, molecules with SH groups, to try to quench the free radicals. But what you get, in fact, is a more rapid activation of the prodrug, which is already sitting there in the tumor by the EPR effect. So you are releasing faster mitomycin C, damaging the DNA, and in fact, when you damage the DNA, you enhance the effect of radiotherapy. So this is I think a nice model. It's really a two-way enhancement between radiotherapy and Promitil. It has been shown to be more effective in disease control in animal models. And we have seen patients already responding very well, as you see in this PET scan of a patient who was with colon cancer for 20 months after Promitil with radiotherapy. His retroperitoneal disease was well controlled and he was still alive at 3 years after start of the chemoradiotherapy. So to summarize, we have, as I said, a very nice result in combination with radiotherapy. 16 out of 18 evaluable patients, 89% were free of target lesion progression at first reevaluation, and with a median survival of the entire patient population of nearly 15 months. And these were advanced cancer patients, and the radiotherapy was given as a palliative measure. And I will not discuss the pharmacokinetics, my time is expiring, but we think that, and we hope that studies will be done to prove that Promitil or PLMLP is an option for chemoradiation therapy to evaluate in randomized studies in the palliative and curative settings. And also, as I mentioned before, since Mitomycin C is active in BRCA-mutated tumors because of the DNA damaging effects. And as you know, BRCA-mutated tumors have a DNA repaired effect. So another study that is actually under planning is a study in which pancreatic tumors, which have some of these DNA alterations in some DNA repair genes, such as BRCA1 or 2, PALB2, FANC, ATM, or CHEK2, will be treated with Promitil in combination with capecitabine, and we hope that we will observe there some interesting activity in these difficult to treat tumors in the metastatic setting. So this is all. Thank you very much. This is an acknowledgement to my team. You see a picture of them there, and to the collaborators who were involved in these studies. Thank you very much.